Welcome to Pharmacytodose, the Critical Care Podcast. And I'm your host, Nick Peters. Wherever you are and however you are listening, thank you. And got an awesome lineup today for the daily recap for Sunday at the ACCP Annual Meeting in Minneapolis, Minnesota. And the episode starts off with so lucky to be joined by Ruben, Santiago, and Megan Musselman, highlighting their talk into hyperthermia recognition and management. And additionally, following that up, if that's not even enough, then we were lucky to be joined by the four speakers of one of my favorite sessions of the whole conference, looking at the utilization of AI in experiential education. So luckily to be joined by all four speakers. They gave insights, and I think one of the big differences between what like some of the previous discussions into AI, like one of the big differences with this is that there's actually practical things that you can take as a clinician to help implement and how to do that more safely in your practice site. So yeah, Zach, Noel, Kaitlin, Alexander, Scott Nye, and Abby Krauter, all lucky to join in that roundtable. So great episode. Let's not wait any further. Here we go. Welcome back. Of course, coming to you live from the Hyatt as part of the 2025 ACCP Annual Meeting. And you know, when we're at conferences, a lot of times we're inside and it's pretty cold. So I got not one, but two speakers that are bringing the heat from a hyperthermia session, right? It's a BCEMP, BCCCP clinical session. Hot takes on the hot body, management of drug-induced hyperthermia. Two awesome guests across from me, Ruben and Megan. So for the listeners who, you both don't need an introduction. For listeners who somehow don't know, let the listeners know who are you and where you work.
Yeah. Hi, everyone. My name is Ruben Santiago. I'm an emergency medicine pharmacist and program director for our PGY2 EM program down at Jackson Memorial Hospital in Miami, Florida.
And a lot of people have probably at least seen your work from drop your Instagram handle.
Oh, and my Instagram is @theEDTraumaCist for all yous out there that I usually don't put my face out there, but a lot of memes.
A lot of memes. I can always tell when Ruben has posted something of mine because I'll get like 100 new followers in a second. I'm like, yep, that's the Ruben effect, baby. Yep.
So my name is Megan Musselman. I am an emergency medicine clinical pharmacist and the PGY2 residency program director for our EM program at NKC Health in Kansas City, Missouri. I'm not as cool as Ruben, but I do follow him a lot on the ED.
Way cooler.
I don't know about
way
that.
Cooler. No, way
but
cooler.
we are going to bring some fire tomorrow.
Oh, I can't wait.
Now, I have to ask, anytime anyone comes on from Kansas City, first things first, all right, what's your barbecue spot?
Oh, I thought you were going to ask me about Taylor Swift.
No. I mean, that could be a topic. I'm pro TS over here, but no, I'm curious. I need the barbecue Rex.
Well, you know, there is a lot of barbecue, and it is better than any other barbecue, if I do say myself. But I'm probably going to be a Casey Joe's fan.
Okay.
But the thing with Casey Joe's is you have to go to the original one that's in the gas station, or you're just not even trying hard.
Shout out Jack Plenicky. He said the exact same thing. So that must be an OG that the real ones know from that perspective. So I like that.
Well, I know Jack, so that's pretty good that he answered that right, or he would hear about it.
Or he'd get a message.
Yeah, that's right.
Okay. So this is like an incredible would you rather. So you're talking about a hyperthermia, right? Hot. So would you rather be cold or hot for the rest of your life?
That's a great question. I do live in South Florida, so I kind of made my choice already. I'd rather be hot. All year long anyway. Right? We have 2 seasons. It's hot, and then it's really freaking hot. So, yeah, I'm cool with being hot.
Oh, man, this is a tough one.
For the record, I gave them no prep because I wanted an on-the-spot answer for this, just for the listeners to know.
I kind of just want to be opposite of Ruben just to be opposite, but I don't know if that's the truth. I'm probably going to have to go with hot as well.
Yeah.
It sounds bad.
When I thought about it, long-term cold seems really bad. Like having to
deal
with that your whole.
I kind of like my digits.
Yeah, like in the
exactly.
I feel like hot's probably the right answer, but then again, there's people who live cold all the time, so maybe that would be the thing. But that's kind of what I thought. All right, so hot takes on the hot body, right? Hyperthermia. So let's kind of start with an easy one. How do we even define hyperthermia? Right? Is it just simply someone comes in to the ED with a fever, or how do we necessarily identify that?
Yeah, it's a great question. So one big thing to know is that fever doesn't necessarily mean hyperthermia, and they're caused by different things. So when you have a fever, that's usually in response to some kind of an infection or adrenal insufficiency. Whereas if you have hyperthermia, you have an elevation in your core body temperature. That's usually in response to a drug-induced stimulus, so whether that's an overdose or a drug interaction that may have caused it.
I love the Spider-Man meme in the presentation, right? Of course, count on Ruben tossing in some great memes throughout. So what are these possible contributors to what can cause that? Because when we're talking high temperatures too, what temperature are we talking about? Are we talking 38, 38.5? When we say hyperthermia, what numbers are you normally seeing?
Well, my Pharmy sense, usually, you see what I did there? It goes off when the temperature is usually a core temperature above 40. I'm like, okay. Now we're talking.
Yep. Once you get to 4.
Yeah, something's hot here, something's not right? And I kind of think about top 5, 6, 7 things that can cause it. And things that we'll go through in the presentation is serotonin syndrome, neuroleptic malignant syndrome, sympathomimetic toxicity, being down in South Florida, a lot of cocaine, right? So,
Cocaine.
Yeah, a lot of, and then things like that. Other sympathomimetics like methamphetamines can also cause it. Anticholinergic toxicity, everyone's trying to get famous on TikTok, do a Benadryl challenge here and there. Those kinds of things are the things I think of and really kind of think about and start having that conversation with the ED team initially, kind of to get the wheels going and see if we need to go down that route and what our options are for treating that patient.
When you're differentiating between all those different, those differential diagnoses that you said, what are some of those things that you're looking for to help? Because if a learner is just looking at them, there's a lot of overlapping characteristics. One, of course, being the big fever. But what are some of you're in the room with the provider, and you're looking at what are things that you're looking for to help rule in or rule out certain sorts of hyperthermia kind of causes?
I mean, obviously, we have those tried and true toxidromes that we can always go back to, but they're depending. I think oftentimes you have to use our spidey senses and think of all the things okay, what were they doing? What did they have access to? I mean, we put together, I really think pharmacists, we're detectives too. I mean,
absolutely.
100%.
Oh, yeah. And we're really good at it.
Yes.
You think you're going to get something by us? We're going to figure you out. We're going to know your name, and we're going to know who your brother is. So anyway, I feel it's just putting all those pieces together, but there's also other indicators as well. For example, rigidity, what type of rigidity, those types of things, which, Ruben's going to go all into that and how to differentiate. And there's different scales and those kinds of things. But we really try to piece all those things together. But oftentimes it's just what you had access to start ticking off your differential and going through those things, or if it's medication induced, you always have to have on your differential, as Ruben already mentioned, infection, other things, that heat related illness, those types of things as well.
Yeah, absolutely. And I would echo that, saying getting a great medication history when available too is going to help tip you off on what's going on and the environment where the patient's coming from. If it's a hot day and somebody comes in, it could be an environmental stressor. The other day we had one that came in seizing, temperature of 40 something, but it was hot outside and he was also on antipsychotics while playing basketball in the extreme heat. So kind of differentiating between the two and seeing what the actual cause is and trying to nail it down that way as well.
Yeah, it's really hard, especially when we're talking about from the EM perspective, to do one size. You really have to, like you said, I love that you highlighted not only patient-specific stuff, but environmental stuff, right? If it's 40 degrees outside, probably not a heat stroke, right? Versus 110 in Miami, it definitely could be.
Exactly.
Now, we're highlighting a lot of this, we're kind of coming from the emergency medicine perspective, which makes sense, right? Two of the brightest EM minds across from me. But is this something that only gets encountered in the ER? Are there things that, iatrogenically we may do to where, this might happen to some of, our folks in the ICU or from, a critical care perspective?
I mean, the thing that comes to mind first and foremost would be malignant hyperthermia is usually something that happens more often, I would say, in critical care or an OR setting, depending on where they are in the continuum of care. Malignant hyperthermia, why we feel like we're pretty intelligent, we keep learning more and more about that mutation. it's one of those nerdy things I find fascinating when you look into it, is that they're learning more and more that it may just not be medication triggers. There can be other stress-induced triggers that they're finding that actually induces this malignant hyperthermia-like syndrome. So I think we're just beginning to get on the cusp of seeing more of this and how to treat it. So I think that's something that critical care pharmacists need to be aware of, because they could have a patient coming from the OR that could be a late presenter, and they're seeing more of the late signs, which is actually when the temperature rises. It's more of a late sign in malignant hyperthermia. It's not an early sign. So to be aware of, so we can do early treatment, because it is one of those things that it's fatal, but if it's treated, almost 90% of patients will survive if it's recognized and treated quickly.
And so like a true medical emergency, malignant hyperthermia, correct?
Yes.
Absolutely. Yeah.
Now, in the presentation, and by the way, everyone should definitely try to go. This presentation is going to be Monday, the 20th. You highlighted a really cool initiative that involves like a team-based response to malignant hyperthermia. So if you can, because I think a lot of us, we know the CART, right? And it's something that like Joint Commission's coming, so it's all like, remember this, but like talk through a little bit more about your team-based response, because like you said, it's a medical emergency, and a multidisciplinary approach feels like is always a really good way to attack those sorts of things.
So it came about just what you just like teed that up for me perfectly. Thank you.
Nope,
so
there was no communication beforehand for the record.
So it came about that I was part of a group whenever this was a hot topic for Joint Commission.
Oh, yeah.
I don't know how many years ago. It's been a minute, but it was. And I was there and I was part of it. We had this wonderful plan. That plan worked great for Joint Commission. But then if you still didn't work there or you're part of that group, nobody understood it when we went back to revisit it. So we had people who were in this plan in groups that didn't even know they were a part of the plan. We had carts that had gone rogue, meaning that depending on the procedure area, they had started putting their own stuff in their carts, and they weren't matching up. So we brought the gang back together again, and we all got through, and we're like, how can we standardize this? Like, what do we really want to come from this? So we actually started with standardizing the carts and making the carts make sense, not just this hodgepodge of, random stuff. So like the drawers have purpose. I know that may seem silly, but it's
There's
something
some people
that
with shocked faces listening right now.
Like something as simple as that. Like, okay, here's the medication drawer. If you need to do lab, that's lab. If you need to cool them, here's all your devices for cooling. If you need to like help with respiration, here's all your stuff. Who knew? Mind blowing that if you organize that, it's more strategic. I know, but sometimes you just got to get the right people around the right table. So that's where we started. We standardize it. It's now an exchange program, probably similar to most people do with their code carts, to make it standardized. And that was really just the beginning of a bigger project that came out of that. And we did we did develop a rapid, multidisciplinary rapid response team. And we were very particular in how we approached it, because we wanted it to be similar to other responses. So we named it Code Malignant Hyperthermia, because when it's code blue, what do you do?
Yeah, code blue.
You're ready.
Yeah.
Right.
You
And
understand the urgency.
That
Correct.
Nomenclature meant something. And so we started there. We put it into all the other systems that we would call code blue, all those types of things.
It's called overhead, exactly
called
like
overhead. It's paged out the exact same way. And then we got all the correct people, and we also made it to where it could be deployed anywhere in the hospital, because that's one of the things that we have learned is while the OR is most likely going to be the area this occurs, it can happen in the ED. It can happen in critical care, especially if it's a quick turnaround and they have them go stabilize in critical care. You've gotten those cases where they're,
100%.
yeah. And so we have made it to where what we did, tiered approach to education. So tier 1 is the people that would be managing these patients, taking care of them, so it's more in-depth education. And tier 2 is just anybody that may come across them, so it's much more just surface level. How do you recognize it, know it? And that's done annually. So it's not we come back in 5 years and be like, remember that grand plan? Well, only one person was here when we did it, and what did we do? And so it was a big overtaking, but it's going to be so worth it. We're talking about it versus trying to figure out what we really meant by it.
Well, and I think too, highlighting like this is one of like the biggest like high risk, low utilization sort of interventions. So like when you mentioned we'll go back in 5 years, that you might not actually have a case in that 5 years, right? And so I love the idea of planning and such. So What are some, when we're thinking of obviously the treatment for it, dantrolene, right? It's going to be in that cart. So when we're using it, what are some pearls on how we're giving that? Like, it's a pretty big dose. Like, are you trying to reconstitute all of that stuff up front? Do you do it one by one? Because like, only talking through, because there's plenty of people who have heard it, but not necessarily been involved in one of like the treatments or in that sort of scenario.
Yeah, I think the biggest thing I would tell any pharmacist is know which product you have.
Exactly.
Yes, because if you don't know which one you have, you're going to fumble because it depends.
What?
Because the vial sizes are so much different. The milligrams per vial. So if you have like brand name Dantrium, you may be using multiple vials to get the same dose as you would for one of Ryanodex. And if you're walking in on that and you're sitting here like, oh my gosh, why do I have 36 vials in front of me? What am I doing? We've always been taught if a dose is more than 4 vials, we need to start questioning, right?
Yeah, something's probably going to be wrong.
Right,
yeah.
Exactly. And so in that situation, you are going to go past 4 vials if you have that. And so that's like the biggest thing is that we teach recognition of product. And I mean, stuff's not cheap. So
and that's the biggest thing to highlight is like a lot of places, I'm sure the vial where you're doing less is just going to be more expensive.
Correct.
Like,
right. So you need to be aware of what you have and what product. And kind of talking about the team, that's something we did was it helped highlight outdates. So we weren't sitting on all of our inventory expiring at the same time.
Yeah.
We have a rotation,
that's a really good,
those kinds of things, because it is very expensive. Like you said, low utilization, high risk, but also high cost. So we wanted to be mindful with that as well. But I would say the biggest pearl, and I'll let Ruben chime in as well, because I know he has experience on this, is just to make sure you understand the product, what you're using, and how it is mixed, because you have to mix it with sterile water. It is not stable in any other diluent. I think would be the most important thing, whether it's the pharmacist that's mixing it or other personnel, just make sure they're aware of that and make sure that signage of how to mix it is 100% clear, because it's truly what that patient needs to help them overcome the malignant hyperthermia.
No, absolutely. I think, and then knowing like the algorithm, the order of which you're going to use products. Some hospitals have multiple products on formula, like we have Ryanodex and the other formulation on formulate, where our anesthesiologists will use Ryanodex first when they have a really high suspicion of malignant hyperthermia to get that first dose in quickly, and then be able to reconstitute the other vials for subsequent doses.
See, and I had read about that.
I didn't. Actually, a really good
right. So when you go to the you would go to the infusion after. I wondered if people really did that.
Yeah.
So. Wow, I've met someone.
Well, because like instantly from a medication safety perspective, you're like, like kind of red flaggy. But when you describe it, that actually feels like a tremendous application of that.
So do you like put the push in with the cart? So you're giving the push, the 1 mg per kg push is the Ryanodex, and then you're like, okay, well, when we're going to go to the continued doses or the infusion, it's coming from
Yeah.
Exactly. My mind's blown.
That's a really good idea. Yeah, and like so that the people kind of understand, right? Like the Ryanodex is like I think it's like 250 milligrams, and I think the dantrolene is like 25, much smaller. So it's you're making big changes. So love that. What a cool initiative. Getting to kind of highlight that too. Now, when we're kind of shifting disease states, and when we're thinking about the treatment of hyperthermia, right? And we mentioned like toxidrones. Anticholinergic toxins is like a classic one, right? And one big change in that, right, is the lack of physostigmine, right, or our quote-unquote kind of antidote or treatment for that. So in that setting, when most places don't have that option, what alternative treatments or things do we have from like an antidote perspective?
So
I feel like somebody published on this.
Yeah, shout out to lead author Brian Gilbert on this one. We just
like
published,
other names were on it too, though.
We just published a nice case series on the.
I was going to say it was
a case report and review of case series of using rivastigmine actually as an alternative to physostigmine. The other option is if you can get the international physostigmine, is anticolium, I believe it's called, that you could use as well.
That's a great brand name as an aside. Yeah. Anticolium. Wow. Okay.
I feel like I missed my calling there.
Well, you know how the names get picked by us? There's like 3 women in California that pick the brand names. They're like in charge of it. It's wild. There's like a LA Times article about it.
Amazing.
That's all I think of when then. Okay, continue. Side tangent over.
So you can use oral transdermal rivastigmine for these bad anticholinergic overdoses to help mitigate the patient's symptoms when they present to the ED and continue it on, usually in the ICU arena as well.
And then, of course, too, is it still for symptom relief, trying to give benzos if needed for
absolutely,
that sort of
that's still, yeah. Hey,
okay, true.
If your Addy's not on shortage.
We're dealing with the lorazepam shortage right now. You're absolutely right. Okay, we got in with this. How much fun was it preparing a talk with you two? Like, because you should see the dynamics here. I think this is going to be an incredible talk. Is there any, how did that go? Is there any kind of subtle shots at one another in each other's slides or anything like that?
Oh, no, actually there wasn't. I have to tell you what, Ruben is always going to be the number one hype person that you're ever going to meet. So, I mean, like seriously, you couldn't be around a better person. So I honestly am honored that I got him to speak with me. But I mean, he's always like, sweet. Even if there was a point where it's like, why did we sign ourselves up for this? Or what are we doing? He'd be like, this could be great, and send a meme, and then it'd be on Instagram, and it was just amazing. I mean, everybody, you should have Ruben as your hype guy, just letting you know.
I mean, genuinely, Ruben, you're the absolute best.
Oh, thank you guys so much. I appreciate that. No, it was awesome.
Too much, but yes, that is an absolute fact.
Well, one of the things I remember is as a resident seeing Megan's name in all these papers, and then when she reached out to like, hey, you want to work with me on this presentation? I was like, oh my God, absolutely. I was like, there was no way I was going to say no to this. Yeah, I was like shell shocked. I was like, oh my, absolutely. I texted my old RPD like right away. Not old, sorry, I didn't mean to say that. My RPD right away.
Sorry, Mary Beth.
Sorry, Mary Beth. Love you. Adrian was like, oh my God, you have to do it. I was like, yeah, it's already done. So
now, how are you doing coming from Florida to Minnesota?
It's cold. Yeah. it's muy frío.
We need to get it hot in here.
Yeah.
I can think of no better way to end than that. So, Ruben, Megan, thank you so much for coming on, highlighting a little bit about it. Again, everybody, if you're here at the conference, be sure to go to their session tomorrow morning. It's going to be great. I appreciate you both coming on. What a great day.
Thank you for having us.
Coming to you live, of course, from Minneapolis, Minnesota. It is the second day, Sunday, from the 2025 ACCP Annual Meeting, and one of the themes of the daily episodes has been AI, right? The first day was Allen Iverson. The second day was artificial intelligence. It's only right that we bring in the 4 esteemed speakers from the Education and Training PRN Focus session, AI as your co-pilot, utilizing artificial intelligence to reshape pharmacy education, precepting, and mentorship. This was the session I was telling them from the moment I saw the schedule. I was very interested in this because when you look at the objectives, a lot of the sessions have always just done like, what is AI? What's the history? What can you do? But this getting more of like a practical aspect from a pharmacist perspective. So excited to dive in. So without further ado, we'll kind of go around the literal round table here. We'll kind of do introductions. So we'll go right to left here.
Excellent. Thanks, Nick. My name's Abby Krauter. I'm a clinical pharmacist in internal medicine at Mayo Clinic in Rochester, Minnesota. My other hat outside of clinical work is as a PGY1 residency program director, so I spend a lot of my time in clinical practice and education.
Toughing out an Achilles is what I hear. You and Tyrese Halliburton.
Yes, he's referring to my scooter friend, which has been with me throughout the conference, has allowed me to get around as I tore my Achilles recently. I'm definitely the only person at the conference on a scooter, so that does make me stand out, and I'm looking forward to trying to get to the podium when we speak later this afternoon.
We hope it's handicap accessible for you.
And my name is Scott, and I'm the manager of experiential education at Mayo Clinic. In that role, I get to oversee our students, our interns, our pharmacy residents, also work with our RPDs, our assistant program directors, and our colleges of pharmacy. Obviously, an interesting field that we're navigating and trying to work through all of our everybody across the nation.
And I'm Kaitlin Alexander. I'm a clinical associate professor with the University of Florida College of Pharmacy, and I also practice in the trauma ICU as a clinical preceptor at UF Health Shands in Gainesville.
And I'm Zach Noel, associate professor at UNC Eshelman School of Pharmacy. Nick, I have a question for you, and that is, did you use AI to come up with your initial AI, Allen Iverson, play on words?
Not at all.
That is impressive.
Right off the cuff.
That is impressive.
All right, so let's kind of set a base. So when you all were approached kind of for this talk to be speakers for it, generally speaking, what was your comfort with AI? Did you use it? Did you like it? Like, what was your kind of thoughts on using it as you were like coming into this talk itself?
Yeah, I can start and say, relatively speaking, preparing for this talk, I'd probably come through a lot of the phases of comfortability with AI. Part of the reason we kind of raised our hand to try to want to speak on this and kind of share what we've been doing. But I will say it's been a progression over the past couple of years. I would say a couple of years ago, I was pretty hesitant and a little bit unsure of how I should be utilizing AI, if there's a role for this in my practice, particularly within education. And honestly, it was probably Scott that nudged me more firmly than anybody else when it came to we need to learn about this and find ways to incorporate it within education, because I think it could be additive and supplemental to a lot of what we're doing within clinical rotation settings and experiential education otherwise. So, to answer your question coming into this talk, I think there was a lot of excitement to just share what we're doing. And that's only grown in the process of getting to work alongside others that are using it in very unique and creative ways within education as well, and getting new ideas from them as well.
I would say for me, having practice growing up in an ICU run by anesthesiologists, a shiny new toy is always something that you want to play with. So that was my initial take on AI, and honestly was probably a little disappointed at some of the things I thought it might do, but then that it couldn't do, which I think shaped then how I tried to approach it moving forward and coming into this talk, and really learned some good uses for it, some bad uses for it, but honestly was really excited about a brand new toy.
I can kind of piggyback off of that, Scott, because I'm kind of the same. I like to tinker when I'm educating, whether it's in the classroom or on rotation, do something new, keep things exciting, I think, for myself and the learners. When ChatGPT first launched, I knew nothing about AI and had never utilized it, had never utilized an AI tool, and recognized similarly the possibilities I think that it could have and the changes that were coming for ourselves as preceptors, as faculty, but also as our students change and use AI tools. So I did a lot of professional development. Thankfully at UF, we've had a lot of opportunities for faculty learning on AI, and so I was able to take advantage of some of those things, and through that process gained a lot of new ideas that I felt that I could bring back into the classroom and then with my experiential learners as well.
I think for me, I'm increasingly viewing AI as a thought partner. And so when I was creating the presentation, it was not AI create these slides for me. It was, here's my outline, here's what I'm thinking, and then I feed it to AI to get some other ideas. And then I tweak things and come back and forth. And so increasingly as I use AI, I'm viewing it as a thought partner, not just an outcome partner. Give me these slides, but rather help make the quality of what I'm producing that much better. So I think that's one thing that's maybe changed with my mindset over the course of developing the presentation and learning a bit more about AI.
What a great way of there's a reason you four are the speakers for this. What a great way of explaining that, for sure.
I can't take credit for that phrase. I'm just going to be honest. So, I've learned this from other podcasts, so do not pin that on me.
So your talk goes into like the history of AI and its implications, and you give sort of practical examples. So from a education perspective and experiential, pharmacy based, how long has AI kind of been incorporated? Is this a relatively new thing within AI, or is this something that's been happening for some time that we're kind of just catching up on?
I think what we're all most familiar with recently is Gen AI, which is much different than the broader AI that we could speak of. AI in the more general term has been around and available for many, many years. And so I think what we're really highlighting is the use of Gen AI and some novel approaches with the presentation. But Gen AI, or AI as a whole, has been around for a while.
Yeah, I think when I talk to my friends in informatics, it is not a new concept to them. It's something they've been thinking about for a long time. The access and I think the showcase of it to everybody and anybody has really been what changed how we approach it, how we think about it, and how everybody that we're interacting does with that. Over the time of creating this, even though I've been an early adopter, a phrase that someone told me when just talking to them about them in general was, it's not AI that's going to steal your job, it's somebody that is good at working with AI that's going to steal your job. And that stuck with me as a really important way of why we need to embrace it, but learn the good with the bad and understand how to optimize as much of that good as we can. And that's really changed in just the recent, I would say, months to years.
I do think AI in experiential education, though, is underexplored. And so I think the ideas that we're sharing, particularly with our learners in the ICU, in our practice sites, in the practice settings, and how they can utilize AI in that capacity is different, and some in an area where we can continue to learn more and adapt and explore. And I think we have so many pharmacy preceptors, and not everybody is comfortable with utilizing these AI tools. And so I think it's easy to turn a blind eye and think, well, I'm just going to ignore that, or not take the time to learn more because it doesn't directly impact me day to day. But I think our students are changing because they are all growing up now in an AI era, and they're learning in an AI era. And I think it's going to be really important for us as preceptors to know and understand that, because not that long from now, it's already changed so much, I would say, in 2 or 3 years, right, with how much students are utilizing these AI tools, how much they know about them, and we really need to take the time to try and keep up with them.
And I'll just wholeheartedly agree with Kaitlin's comments there. That's what I was thinking about when you asked the question, Nick, as it relates to, I think it's very new for a lot of people in experiential education and at the front lines of patient care and clinical spaces. But now that it's more accessible and we're seeing more of our learners utilizing it, our preceptors are kind of learning it at the same time as their learners are. And it's an interesting dynamic because they're also the ones that are responsible for teaching ethical and responsible use of it. But talking to people on the front lines, I think there's a lot of just unknown about AI and the different tools that are available. What are the strengths? What are the pitfalls? And how do you balance that when you're thinking about how to best utilize it within their practice? So I think the unknowns lead to some hesitation, and we're just trying to better equip people to utilize it in like an effective way and a responsible way, recognizing it's not going anywhere, like Scott mentioned, and it's certainly going to be a tool that we continue to utilize.
Do you all feel like in the classroom that it's like students are using AI to a much more than like faculty or preceptors are? Kind of that balance? Like, would you say that anecdotally that's what you all are experiencing? For listeners, lots of head shaking around the table.
Yeah, and I think it's changing really fast. So there's some student survey data, pharmacy learners from 2023 that showed that maybe like 20 to 30% of students were utilizing AI for academic purposes, or at least had explored that use. I can share, we did a recent survey last spring at UF of our pharmacy learners. 80% of our students said that they had used AI at some point for some type of academic use. That's a huge jump in a really short amount of time.
Yeah, that, you said 2 years, that difference?
Mm-hmm. So I think that is rapidly changing, and we have learners that are taking AI courses now in undergrad. It's being incorporated in K through 12 education, where students are seeing AI tools very early on now. And so we need to be ready for that with our new pharmacy learners, new pharmacy graduates, with what they know about using AI.
I'll add in, the experiential education space, not seeing as much of the classroom component, but let's say, figuratively speaking, I walk into a workroom where I've got attending physicians, third-year medical residents, first-year medical residents, pharmacy learners, and the learners all have open evidence up on one of their screens. And that's how they're first investigating a clinical question that's coming up with related to their patients. Like, that's where they're going, whereas their physician counterparts that maybe been in practice for 5 to 10 years, we're going to PubMed, we're going to those other sources that we were taught to utilize to answer those questions. And so I think that's just like a visual way to demonstrate like how different generations of providers are going about answering those questions right now, and a little bit of a gap probably between what our learners are utilizing and what our faculty or our physicians, pharmacists are utilizing when they're forming those thought processes or decisions.
If I could play devil's advocate for a moment, and not because there's a restaurant named Devil's Advocate down the road, I recently read an example of how, with the current generation of learners, they've kind of been thrown into this AI space. They're rapidly starting to use it. And the analogy was, imagine learning to drive without getting a license, but being thrown into a Formula One race car and saying, here you go, good luck. And in some ways, I worry less about the AI native learners that are in kindergarten through, middle school and high school, and more about our current generation of learners that were not taught the responsible and right way to use it, to be a thought partner, et cetera. And so I think it's all the more reason we as preceptors and educators have to educate our students. We can't stick our head in the sand and think that, well, I don't have to learn this right now. Students are going to use it. It's not a big deal. We have to be able to teach them how.
Zach, I think what you highlight is why so many faculty and preceptors feel so uncomfortable, is because now we're behind, but yet still ahead in other ways. And the ways we're behind is what feels so uncomfortable. I think a core theme that I always like to reassure people is critical thinking hasn't gone away. It's still a really important thing that we need to teach, we need to showcase, we need to help them. And so if they have access to that information, that foundation at such a more rapid pace, focus on that critical thinking, focus on something else that hasn't changed and will remain constant. The way we approach critical thinking might change, but not the need for it or the application of it. And that's a little bit of a reassurance, because honestly, I feel more uncomfortable than probably our learners right now with AI.
I mean, Abby, the example you gave, that's a real life that 100% happens to me on rotation. And, right, I'm trained. The first thing I'm always telling them is don't Google things, right? Like, that's the first thing. But it took me a little bit to know, like, okay, is this appropriate for them to be using this as their information source, right? You have to change your mindset. And sometimes we're stubborn, right? Sometimes we can be hard to change. And I want to kind of piggyback off, Scott, what you were saying, and Zach, in the presentation itself, you made the analogy of using AI, or at least within your slide deck, using AI for low stakes assessments and creating boundaries or restrictions for higher stakes assessments. Can you give a couple examples of what that means? Because I think that's, to me, when I looked at that feels like a core foundation of AI and its application.
Sure. So I'll give one example. Last year, during a verbal assessment, so students come into the classroom, they work up a case, and then they present to a preceptor. I told students they were not allowed to use AI last year. I've completely changed that this year. I said, if you want to use AI, go for it. But my way of ensuring that students actually know something when they come into the classroom is that I put pretty strict time parameters around it. You have 15 minutes to work up the case and come up with your recommendations and a rationale. And if you don't know something when you come into the classroom, AI is not going to do all of that for you in 15 minutes, short of taking a picture of the case and uploading it, which I have banned. But aside from that, we embrace AI because, as was said, on rounds, what are they doing? They have open evidence up and are looking at information in real time and digesting that. And so it feels just unrealistic, it feels unrealistic to say you can't use it in the classroom. So that's an example of a lower stakes assessment. Yeah. And then obviously more summative exams are there to make sure students have the knowledge, the critical thinking skills that are so important without the use of the technology.
So one way too I flipped the script on rotation is taking a topic discussion and given the students a short case-based scenario and said, put this into your favorite AI tool and tell me about the output. Do you agree with the recommendation from AI? Why or why not? And explain it to me.
Oh, that's such a good idea.
And so they are being tested on their knowledge. Did you prep for this topic discussion by reading the primary lit that I asked you to, by going to the guidelines? And now I want you on the fly to critique this response using that preparation and sharing with me what you know about the topic. And I have really enjoyed doing that activity. You can have it with different levels of learners. So with APPE students mixed with residents and small groups, they can compare and contrast the outputs that they get because every output may be different. So one student may get one answer to a question, another one may get a different answer, and then they can talk it out and decide within the small group what recommendation they most agree with. And that has taught me so much more about their knowledge and opened it up to say, yes, I want you to use AI, open up your computers rather than taking that banned approach.
One area that I sort of see an avenue is like AI from like an evaluations sort of or assessments perspective. So how has that, or how do you all use that from sort of a non-clinical side of things? Like maybe like whether it's, letters of recommendation, evaluations, those sorts of things. Because to me, as someone who letters of recommendation take a really long time, I actually have utilized it and it was really helpful. So are there other areas within those sorts of kind of like administrative or task-based things where AI has really, like, you all have found has helped you all?
We just had our accreditation site visit for residency, and one of the things that we are improving upon is the feedback that we are giving to our learners and ensuring that it's constructive. And so we were given examples of what that could or should look like. And so on this recent evaluation that I did last month for a learner, I took that template and gave that to AI as an example and said, this is my feedback for this student, but can you help me frame it in this way? And so that way we're ensuring that we're hitting that, accreditation requirement for our site visit and just helping with the formatting. So the feedback that I was giving was all mine. It was personal to the learner, but it was just helping with that formatting, making sure that we don't, miss any of those boxes that we're supposed to be checking.
I won't lie, when you led off and you were like joint commission, I'm like, oh, I definitely been doing something wrong.
Oh, not joint commission. This was residency accreditation.
So yeah. Either way, I definitely thought it was going to be coming from the point of like, you're not supposed to do that. That's what I expected. But that's a good example of using AI to improve, right, based on feedback that you all given, right, from a program perspective.
Yeah, I'll just echo that. It would be really helpful. I was sad that my accreditation visits were probably a little bit early in my AI journey, that I didn't utilize them well. But I think for like administrative tasks or like standard operating procedures, it saves me so much time. The one thing that I've really challenged, though, is to not use it when reflection is really important. And so, like, I comment for learners, it can help you in some verbiage or some wording in a letter of intent or a letter of recommendation or feedback, as long as you've had the reflective thoughts first. I think Kaitlin's example hits on that well. I've even had a little bit of a project for my ChatGPT that asks me certain questions to help stimulate how I want to write a letter of recommendation. So I actually use it to help me reflect, because I have it loaded with several examples of what I like to do, have it ask me some prompting questions, have me respond, and have it ask follow-up questions, which actually helps me get in the really good mindset. I think it could be used either way. The one thing I would say is don't let it do the reflection for you. It can either help stimulate the reflection for you, or once you've done that reflection, it can help you with the output, but don't steal that valuable piece from your work process.
So Scott, that's something I've done with experiential learners too, is ask them to engage in that interview process with AI when they're doing their midpoint or their final evaluations, because so many times they do the evaluation and they just go through and check the box like, yes, I'm doing great, I think I can improve here, but there's no comments and there's no real reflection that's happening with that evaluation. And so they can generate those examples using this interview technique with AI and then put those into their evaluation. And I also tell them that another benefit of doing that, though, is that they start to generate specific examples from that experience that they can use to put into their letter of intent, that they can use in interviews for situational based questions, rather than getting to interview season for jobs for residency and not being able to remember, what did I do 8 months ago on rotation and what example am I going to give when I was directly impacting patient care. Now you've already engaged in that self-reflection in real time.
I was just going to piggyback off of something Kaitlin mentioned when she was talking initially about using AI to improve evaluations and the quality of those, the structure of those. Something we're trying to do at our site is kind of create a preceptor toolkit for how can you utilize AI within experiential education. And one component of that is like example prompts and some of them are more like logistical related. How can we improve not only evaluations, but the bane of many preceptors' existence is updating learning experiences and writing activities that match Bloom's taxonomy and all of those things, and have found a lot of utility there, where I don't know that we're losing the intent of the activity when we're doing it, but potentially creating higher quality documents to guide learning experiences. But also things like, I have to give challenging feedback to a learner. Can you walk me through the process of how I might phrase that in that conversation? So kind of simulating some of those conversations that a preceptor might have to have, and getting potentially some feedback from the AI when they're just practicing what that dialogue could look like. So a lot of different examples, both logistical and some of those like soft skills, professional development related things too.
What strategies would you give to preceptors who are looking, who are looking to become more comfortable with AI and using it. They're hearing some of these things. I'm assuming one of the pieces is diving right in, but was there any other things that you all have done that helps make you, because I mean, like Zach, some of the considerations you're talking about of like, oh, well, they can't scan the image or upload it. It's like that didn't even enter my mind as like even like a possibility. So what sort of things, like how did you get more comfortable with it?
When I was first starting to use AI, I had a daily recurring task that just said, use AI. Because the reality is we are creatures of habit. And in order for us to change our behaviors, we have to have some sort of reminder there initially. And so that's the way I started. And now I've taken the approach of at least 10 conversations a day. 10 prompts a day with AI, trying to improve the quality of my work, again, the thought partner type of thing. And so that would be a challenge that I would give to your listeners, is just 10 prompts a day. Whether it's as simple as finding the coffee shop around here or maybe improving a slide deck or a manuscript, but engage with AI 10 conversations a day.
Or use a new tool, I think, too. Try a different tool once a week. I think exploring them can be really helpful. Abby mentioned earlier, open evidence can be a great tool. A lot of times it pulls from guidelines, less from primary literature in my experience, where it's really good at summarizing those guidelines if they're out there, but has some limitations. And unless you use it regularly, then you may not recognize what those nuances are and what some of the strengths are of some of the different tools versus some of the weaknesses.
I'll just add that if you can think about tasks in your day you feel very competent to do, but you know they're a little time consuming and you kind of want to experiment what some help could be, I think starting off with those in AI are helpful because you can evaluate the result very well. You can probably change how you're prompting with it to ultimately get what you want, and that'll build early success, which will help promote future use. And so I always think early success helps people continue to use it. If you do something super challenging first, you're probably going to be steered away from it a little bit. I think also just looking at a prompt and not thinking about just one line or how fast or simple would I have done this in Google, but can I create a little bit more of a robust prompt will help you be a little bit more successful as you're learning. And you can even ask AI to say, can you help me build a better prompt? Are there things I should have included that I didn't, or questions I should have asked, or do you have any questions for me to most successfully execute my task? There was a whole field of prompt engineering that was essentially created and might even be kind of going away or falling in the wayside in about a year because now AI will help you create those prompts. But it's garbage in is garbage out. So if you just do one line, you might not get exactly what you're looking for, where if you give it a little bit more up front, you're actually going to get more success. So I think those early successes and really focusing on the prompt for early users will help you be so much more successful and get more creative and more experimental with it.
And don't be afraid to give the AI feedback. I tell my learners that too. They say that they entered a prompt and they got a response and it wasn't what they were looking for. And then I'll ask them if they re-prompted or asked it to be reformatted. And they say, no, I just stopped there. It wasn't what I was looking for. And so if the AI generates bullet points for you, but you really want something in a table, then ask it to put it in a table and it can do it for you. So I think remembering that you can have this dialogue back and forth can be helpful.
The only thing I'll add, I agree with the comments that were made. I think what was really helpful for me early on is like someone a couple of years ago that knew very little about AI to someone that knows, I would say, a good amount, but not a ton now, would just be, what is AI? Learning about the risks of it, the benefits of it, those types of things. So really starting from the ground up for those that maybe are really, really new to it. I think that was helpful for me. And I think the other piece that's important for someone that's just going to jump in and start utilizing it is to really ensure they're critically thinking about the output that they're getting. Because I think that too can build an awareness of what does it do well and maybe what does it not do well. And that can inform when I choose to utilize AI in the future and maybe when tasks or certain situations when I'm going to probably stray away from it because I recognize it's not what AI does well. I learned that through kind of reading about it a lot, kind of doing some modules, those types of things, but I think you could learn about it from experience as well, as long as you're critically thinking about the output that it's giving you.
Should we be over concerned in terms of what AI platform they're using? Like, should we be focusing on, I think of, like you said, I think it was open evidence or open AI, or that's more of like the medical side, but should we be focusing on how they use it, or which kind of AI like software they are using, if that makes sense?
I'll start it off, and I'm certain there'll be more thoughts that could be added. I think what I've come to appreciate is that every platform has a role depending on what it is that you're trying to do. If you're trying to, potentially just revise an email, there's a platform for that. If you're trying to identify medical information, there's a platform for that. If you're trying to do a lit search for research purposes, there's a platform for that. And recognizing the lane that each platform has and in what scenario it's probably best going to be utilized is probably the direction I would go more than anything. And that's where a lot of like my understanding has grown, is that each of these platforms has different strengths and can be utilized, I think, in different facets, but it's understanding where that role is.
What strategies do we need to be in place? And I'm kind of thinking more from like a kind of experiential, like they're on like clinical rotations. What sort of like safeguards or things do we need to use, or how can we do it to make sure that they're utilizing AI or not using it for, like we were saying, these tasks that we want to make sure we're evaluating them, right, and not the software itself? What sort of like safeguards or monitoring or things can we do, like for those who aren't necessarily in the didactic classroom, so they're going to have just less knowledge about all of the nuances in general?
So I'm going to touch on that in our session later, thinking about how you may revise or approach assignments or assessments in a different way, knowing that students have AI tools available to them. Because if you haven't already, if you have an assignment that you routinely give to students and you haven't put it into AI just to see what the AI output looks like, I highly suggest you do that, because that'll kind of give you the foundation of knowing what the AI capabilities are, and then allow you to up your game of what your expectations are for the student, because we want to motivate them to be better than the AI.
I like to reference back to the Dunning-Kruger effect on this one, where something that's a real risk that you can think about is they might have a little too much confidence when there's not enough competence for it. And really, that's going to be through interaction. It's going to be through asking questions. And ideally, you want to get them over that hump so they continue to progress on their competence level. And their confidence should decrease a little bit. I actually think holding a few examples of when AI steered you wrong to share and to showcase and to let them know to critically evaluate and question is really good. I think always, challenging the other side so they, feel more confident in whatever their ultimate decision is, but they can see that it's not as simple as one answer, as we always talk about the gray, but really pushing them beyond that. And I think if you take the approach of asking them to do it, like Kaitlin talked about earlier, that's a really great way to encourage it, but let them know that there's still things to learn. I think if you tell everybody no, it's going to be the parent effect. Well, all of a sudden as a child, I want to go and break my parents' rules and do it. And then I might not tell you about it, versus if you're open and transparent about it, I think you can have a much better conversation of pushing them past that Dunning-Kruger peak into actual more competence.
I mean, a major theme throughout all of these answers, though, is using AI. The only way that you are actually going to be more comfortable and be able to integrate it is, my takeaway, one big takeaway, is you just got to use it more and have it be a part of your everyday life. Is that, other than, I like the idea of reminders, are there any other strategies or ways that you all did to help incorporate it more, to have that be part of your sort of daily routine?
Depending on the institution that you are at, one strategy that I found particularly useful is hearing use case examples of what others are doing. And you have this kind of aha moment that, such and such is using it for this with their patient care or with their administrative task, and it's worked really well. And that kind of inspires you to explore some. And so maybe it's a learning community that you get together once a month and just share use case examples. But something where you're learning from each other, I think that's the most powerful way to kind of motivate us to want to do it more, rather than just wandering into this universe of AI that feels too vast to do anything with.
We're at the ACCP Annual Meeting. It definitely, like you bringing that up, it kind of sparked my idea. That feels like a little subgroup of a PRN sort of activity or some sort of collaboration, because that's a really good idea. Because it feels like how I find out about most of the AI things is word of mouth. I find out very little from online, and it's more about how my colleagues are using it, how they benefited from it, like all the strategies you all said. So that's all right, hopefully people from ACCP are listening. That's a good idea. All right, I like that. Well, this was, awesome. Everyone, if you're here, you should definitely make sure you're at this session. But Zach, Kaitlin, Scott, Abby, appreciate you all for coming by, not only talking through AI to a non-AI person, making the strong push is why I needed to use it. But also, I think the best part that I liked is giving practical strategies, how to do it safely. And not only just in the education, the classroom setting, but also in the kind of experiential, kind of real world setting as well. So can't thank you all enough. Thank you so much. This was awesome. Another huge thanks to all 6 total guests that came on, taking time out of their really busy conference day to help share some insight into their sessions for those who are here, but also for those who aren't, and get to expand on some of those topics. So loved both of those. Great discussions. Remember, here through Tuesday. So if you see me, let me know. Always like to say hello. We'll have some swag, pens, badge tags, etc. Look forward to seeing everyone at the business meetings. And until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.